between two different things. So what we're looking to do today is bring together the implementation science interest group and also bring together the with the implementation science reviews, which is a new initiative that Sarah started on Twitter, and she will talk more about this. So perhaps I can just quickly tell you a little bit about Sarah. Just got to accept that it's being recorded. Lovely. So Sarah is a registered nurse and has a PhD, and she's a lecturer in acute care nursing at the University of Sydney. She's still an early career researcher, having completed her PhD through the University of Sydney and investigated the implementation of a care bundle for patients with blunt chest trauma. Many of you will remember her talking to us about that work, a very interesting piece of work that she did for her PhD. She's worked as an emergency and trauma nurse for 15 years at St George's Hospital in Sydney, and her current focus is around scaling up implementation and improving emergency care. So Sarah, can I hand over to you and you can share with us how we're going to run today? Looking forward to it.
Thanks, Steph. Before we start, I also want to acknowledge the traditional owners of the land, and especially since it's Reconciliation Day and week this week. I'm on the Gadigal. I'm sorry, normally I'm Gadigal. Today I'm on Dharawal country. So yeah, thank you for having me. I think it's a really great idea to have this mash up, as you said. Karen, do you mind just stopping the sharing?
Yep.
So today we're going to do that way. Thank you. That way I can see everybody. Today we're going to do two papers. This is only our second meeting for implementation science review, and it kind of started because I wanted to meet up with people that also were doing implementation science, because I feel like it's a smallish world, getting very quickly bigger, but it's kind of nice to collaborate with everybody else, but also do a journal club that wasn't in a boring way. And do it on Twitter as well, so that we can reach more people. And if you can't make it to one session, then you can follow along on Twitter, and at least you kind of get the gist of the conversation or the paper, and can keep up. Just there's so much literature coming out so quickly that I feel like I can't keep up with it all. And so this is kind of my attempt to try and keep up with it. So today we're going to actually talk about two papers in about 20 minutes each. Each time that we do this, we'll probably just, I don't know, it's so far been a little bit random. I kind of initially wanted to have a classic paper and then a more recent paper to talk about. We can change that as we go along with it. The two papers that we've got today are the first one by Walsh Bailey et al. Is the scoping review of the implementation frameworks and models. And the second is by Bronson et al. And it's revising concepts of evidence and implementation science. So we'll do the first one, the scoping review first, for about 20 minutes, and then the second one as well for 20 minutes. We kind of have some questions to initiate discussion, but really happy for anyone to just jump in. It's really, like, I haven't prepared a presentation or anything, like it's very casual. If you haven't read the papers, that's also fine. I'm sure you'll be able to keep up. Just stop me at any time, yell out if you want to, put your hand up in Zoom, whatever you feel comfortable with, write in the chat. All of the above are acceptable. We're not fast. Right, Steph? So the first one is the scoping review. But I thought before we start really quickly, I just thought if we can just go around really quickly and just everybody just say who they are and where they're from. So I'm Sarah Kourouche, I'm from the University of Sydney. Is it better if I yell out people's names?
Yeah, I think so.
All right, Steph.
Sorry, I've got my phone ringing, it's cutting off my headphones and fiddling between screens. And oh yeah, no, Sarah, I'm really excited about today's session. So glad that you can join us today. So yeah, I'm Stephanie Best. I am an associate professor in implementation science based at the Peter MacCallum Cancer Centre and the Victorian Comprehensive Cancer Alliance, and also working with Australian Genomics. So it's a bit of a long title, that one, a bit tricky one to try and get into those small spaces they sometimes let you have on paper submissions. So yeah, so that's sort of my rough background. Would you like me to nominate somebody
You're too
else
successful.
now,
Go for it.
Can I nominate Ebony?
Hi everyone, my name is Ebony and I'm from the University of Melbourne and I'm a PhD student. I'll nominate someone. I'll nominate Nicola.
Thanks, Ebony.
Thanks, Ebony. I'm Nicola Cray. I'm also from the University of Melbourne and also a PhD student. I will nominate Karen.
Hi, I'm Karen Hutchinson. I work at the AIHI at Macquarie Uni and I'm working on some Rural Kids GPS program, which is a care coordination program for LHDs. And I'm also an honorary scholar at Central Coast Local Health District. I'll nominate Andrea.
Hi, I'm an ECR at the Daffodil Centre, working on a number of different projects, with some with an implementation focused in advanced supportive care and advanced cancer, and a little bit in melanoma as well. And I will nominate Helen.
Hi, I'm Helen Brown. Sorry, I just choked on my biscuit. I'm from Deakin University and work in knowledge translation across the health department faculty. Sorry. Thank you.
Natalie?
And yeah, sorry, I should have done that, shouldn't I? Gosh, I'm a bad game player. Go, Nat.
Hello everybody, I'm Natalie Taylor. I'm an associate professor at UNSW in the School of Population Health. I've worked with a few of you on the call for quite some time, so it's really nice to see some familiar faces. I've tended to work across cancer and genetics and genomics, but I guess expanding out into lots of new and different areas now. I'm in the School of Population Health, which is nice. I skimmed the papers today, loved the second one and really looking forward to talking about both of them. And nearly forgot, I'll nominate Claire.
Hi, how you going? I am Claire Zammit. I'm also a PhD student from the University of Melbourne, and Nicola, Ebony and I are actually from the same team. We're from the Evaluation and Implementation Science team at the Centre for Health Policy. And yeah, my work currently is to do with self-collection in ARCHOs, but I've also done some implementation work in clinical genetics with an Indigenous kind of Aboriginal and Torres Strait Islander focus.
Can I nominate someone? What about Samantha?
I knew it. I knew you would do that, Karen. Hi, everyone. I'm Sam. I'm a postdoctoral research fellow at Macquarie University. Currently working across looking at implementation of in primary care quality indicators in skin cancer care and management. And I'll nominate
Hi everyone, I'm Jack. I'm a master's student at UNSW and I'm also working as a research assistant in the Rural Kids GPS project that Karen mentioned earlier. Let's throw it to Erica.
Hi everyone, I'm Erica Breuer. I work as a consultant / freelance researcher, mainly doing work around participatory program theory development in mental health, a little bit in social care, and I'm an honorary lecturer at the University of Newcastle. Jill?
Hi everyone, I'm postdoctoral research fellow at Deakin University based in Geelong. Healthy eating and physical activity in children using systems approaches and incorporating that with implementation science. I'll throw to Penny.
As I knew you would. Penny Love, also at Deakin University with the Institute of Physical Activity and Nutrition. Dietitian by background, and my research is on, I suppose, healthy eating in children under the age of 5. Busy working on an implementation trial for a program called Infant, which is looking at the sort of 0 to 2-year-old healthy eating and active play. And I'm not sure who has not been nominated. Perhaps, Sarah, you could see.
Hasai? Sorry, you're eating.
I'm so sorry, I was hoping no one was brave enough to say my name. Hi, I'm Hasai. I'm a lecturer and an implementation scientist at the University of Technology, Sydney, at the Transdisciplinary.
Congrats on the new job, by the way.
Thank you. I submitted my PhD not long ago. It's under examination, and Stephanie Best was my supervisor.
Beep, beep.
Yeah.
And Natalie as well, new job? Sort of. Okay. Heather?
Sorry for joining late. I'm Heather Shepherd. I'm a senior lecturer in the Faculty of Medicine and Health at the University of Sydney. I'm a nurse by background, work with Sarah a little bit, though we don't work directly with each other, but we have very many shared interests, maybe we will in the future. My research has really been around health literacy, shared decision-making, health services focus. I've been working for the last 5 years on a Cancer Institute implementation grant, looking at implementing clinical pathways for anxiety and depression. But yeah, lots of different projects across different ways of looking at the applied side and implementation side, and obviously teaching within the school here as well.
Thanks.
Oh, I don't know who's missing. Who have we not?
Angela, I think, hasn't gone yet.
Or Leanne, maybe. She's joined.
Hi, I'm Angela. I'm an implementation practitioner and scientist. I'm in between roles, and my new role is about to be with the Health and Social Care Unit at Monash University.
Awesome. Jane?
Oh, hi everybody. My name's Jane Montgomery. I work at the Agency for Clinical Innovation, which is part of New South Wales Health. I've got a nursing background and I work with the implementation team, so I'm just very interested in using implementation science in practice just to make me more efficient in my role. Thanks.
Awesome. Leanne?
Thanks, Sarah. Hi, everyone. I'm Leanne Hassett. I'm an associate professor at the University of Sydney. I'm a physiotherapist by background. My research is predominantly working with health professionals, often physiotherapists, to embed physical activity promotion into their practice. So running a number of different trials around that. And I'm about to take up a new position, little 0.4 position with Sydney Health Partners in their implementation science team. So I'm looking forward to that.
Awesome. Is there anyone else?
I think there's Bella. She just popped
Bella?
in.
Hi. There's so many people moving around. Bella?
I think she's frozen, is she?
Okay.
Yeah.
Samantha?
I think Sam, she's introduced herself.
Oh, okay.
Yeah, yeah.
All right.
Also good by Sam. So Sam. Yeah.
Okay, well, let's get started. Great to have everybody here. It's awesome. So we'll do the scoping review first. Has just like a tick on the reactions. Has anybody read it? Just so I know.
Yeah.
Yep, a few people. Okay. So just first of all, just thought I'd say why I chose this one. Last time in the review group in the Journal Club, we did a paper, and I should have written what it was because I've forgotten the name of it now. But the paper really mentioned that an area of research that was needed in implementation science was de-implementation. And I thought, I kind of know what that is, but I don't really know what it is. Like it makes sense as what it is, but I thought it'd be interesting to delve a little bit deeper about what it means. And yeah, so that's the kind of why I chose it. So I just thought we'd start off by just opening it up to everybody else. Like, have you heard of de-implementation science? What do you think it is? Feel free to just jump in whenever. What does it mean to you? Or has anyone done de-implementation research?
Yeah, I have. I've done it through a health service here in Melbourne called Monash Health, and it was the reduction or stopping of unnecessary care that could cause harm, or there was no evidence of effectiveness. So we used the implementation science approach to consider it, and also included consumers in understanding the barriers and enablers to de-implementing something. And this project went for 12 months, and it was successful while we were there. So we needed another year really to work with the teams, and also to engage leadership. It was very hard getting it into the governance processes, the quality governance processes within the health service, because it did need ongoing monitoring. We tried very hard to get it into the standard auditing processes. It just needed more time, much more than 1 year. And unfortunately, that was.
Did you use a de-implementation framework, or was it just?
No. We were just very cognizant that we were telling people to stop doing something that they really believed in, that they were doing the right thing, that the evidence, presenting them the evidence was very important. But again, very important to consider their response, their psychological response to, hang on, I've been doing this for this long and now you're saying I shouldn't have. So that was an important aspect that actually I would have liked to have focused a bit more on, but we didn't. Had a very small team and couldn't do everything, but started the conversations.
Natalie, did you want to?
I guess talking about that and listening to I'm just going to try and remember the name of the person who was just talking. Where is she?
It's Angela.
Angela. Sorry,
yes.
Angela.
No drama at all.
I guess I was just thinking about the extent to which a lot of implementation projects actually require the implementation, and I don't know how many of these frameworks that were assessed sort of take that into account explicitly as something to kind of assess at the beginning, because I think sometimes you might have an activity that you want people to stop doing and to replace it with nothing else, or you might have an activity that you want somebody to stop doing and then replace it with something else, and that means that you've got both de-implementation and implementation activities to kind of consider, and it's probably worth spending some time thinking about that before you embark on whatever project it is. So it was just an observation really. I always thought, similar to Angela, one of my first implementation projects was probably a de-implementation project because I was trying to support hospital staff to kind of stop doing an unsafe practice. But actually in that process, I had to encourage a new, kind of changing to do something new. And that's quite complex. So yeah, just an observation really.
Yeah, it's almost like you feel like you want to say, here, do this instead.
The other thing we found was the clinical staff, and as is usual in healthcare, are very risk averse. So they really needed to see very clear risk reduction possibilities. So we use criteria. If the patient meets these criteria, the evidence indicates that it's safe to not do this, and the safety net is tell them to come back after 24 hours. So the clinical staff didn't want to be liable for anything. They wanted to make sure that if we told them to stop doing something that they're very used to doing, that no negative action would occur or reaction or consequence would occur. So that was written into the procedure or the intervention communication aspects.
Claire?
Sorry.
Thanks, Angela.
So I guess I haven't had experience with de-implementation studies or frameworks, but the theory is something that we've been discussing on a project that I'm involved in called Stories. So it's basically a big qualitative study that looked at the new changes around the National Cervical Screening Program, and we were trying to look at the data to see if we could look at theories around de-implementation of the previous changes from the previous program. So yeah, we're looking at, and it's going to be led by the person that brought up this theory was Nicole Rankin, who I'm sure you've all heard of from the Sydney people. Yeah, so it's something that I've definitely heard of, and I think it's will be quite useful in trying to change clinical practice or practice that's been ingrained in training, such as clinician collected CSTs and that kind of thing for a long time.
Thanks, Claire. Leanne, Heather, is it okay if we just come back to you, because I feel like we're not going to get to the papers? So the paper defines de-implementation, and I think, Angela, you almost said this word for word, which was really interesting, that its de-implementation is defined as discontinuing or abandoning practices that are not proven to be effective, are less effective or cost effective than alternate practice, or potentially harmful. And do you guys agree with that? Do you feel like that was kind of what you thought it was anyway? Yeah. So it sounds like mostly de-implementation kind of happens as reduction or elimination of something that's inappropriate, ineffective, or potentially harmful. And I think there is so many things. I worked in the emergency department yesterday, and there are things that we do and you just think, I don't even know if this is, but we just do it because this is just what we do. This is just how we do it. This is just the processes.
Yeah.
And it's really interesting to see that, to see this research and see these types of research and see that, well, actually, maybe we should stop doing those things. Any comments on that?
Did the papers mention anything about choosing wisely? So for those in healthcare, choosing wisely is a mechanism that's used to bring these harmful procedures together with evidence-based and expert consultation.
Is that a framework?
Yeah,
no,
it's
they do. Yeah,
association or collaborate. I don't know, what would you call it?
The paper does talk about choosing wisely. In one of the tables, you'll find it in there.
Sorry.
Yeah.
That's okay. Yeah.
No, because they mentioned deprescribing. I guess when I first think about it, I think about deprescribing and how that kind of fits in with the choosing wisely work and all of that stuff. Kind of, it's a bit linked, but yeah, I think it's, I don't know. I have to confess I haven't read the paper, but I'm kind of intrigued by the idea that is de-implementation when we don't put something else in place, or do we consider usual care or no intervention as being an intervention? It's kind of one of those things, and I agree that actually all implementation probably involves some de-implementation, because in the work that I've done, it's often about looking at the workflows in practice and seeing how you might need to change those and alternate those, or different to do things in a slightly different way. So yeah, I guess it's an interesting whether we need separate frameworks or whether we should build, I don't know, into the other one. But yeah.
exactly right, Heather. They actually say there's like the 4 categories that they have in there are reduce, replace, restrict, or remove as the 4 different types of de-implementation. So replace kind of would be in there, and also mentioning that, like you said, integrating it into some of the other frameworks that are already there. Natalie, have you got your hand up?
Yeah, it was just something that you mentioned earlier, Sarah, about you know, we just do things in the emergency department because it's just a done thing, and you know, it's kind of a procedure you know, that's kind of just embedded, but that doesn't mean to say necessarily that all of those things are
the best way
correct. And it was just really to say I've been working with some people from the UK and in Australia on a project called ITNOS, and it's essentially trying to help identify perceived low value practices from healthcare professionals prior to embarking on I guess kind of a selection of different activities to de-implement. So I just thought it was interesting that you'd said that.
Yeah, I thought about it yesterday because I put an NG in because that was your thing, right? I put an NG in a 7-week-old baby. And we were like pulling out the thing, and I thought about your project. I was just looking in the chat just to make sure I haven't missed anything. Mapping. As I said, we're mapping behaviors and using implementation mapping. I've asked if any behaviors need to stop versus new ones. Yeah. Just to actually ask that. Maybe we're not even asking that question. Is there something that we need to de-implement? What do we need to replace? Similar to choosing wisely is wiser healthcare. Thanks, Andrea. And yeah, exactly. It's often a combo of new, replace, and remove. Apparently remove was the most common standalone target though, with 13 studies. So we just actually forgot to say. So their aim was it was a scoping review was their methodology, and their aim was to identify and characterize frameworks or models that could be used to study de-implementation as a phenomenon, and to identify gaps in the literature to inform future model development and application for research. And they had a scoping review, and they looked at 9 databases and 11 journals. And they had they checked the quality, even though it was a scoping review. But an interesting thing that we picked up, Steph, was they only included models that had a visual representation, but they included everything like grey literature, study protocols, commentaries, and things like that. Did anybody have any other comments on the methods or aims from people that have?
I thought it was quite interesting that they only used selected examples that had a visual representation. That seemed to be quite an interesting way to sort of, I know you need to cut down your papers when you're doing a review, but I just thought it was quite an interesting approach. And also I wondered whether that would make analysis quite difficult as well, potentially, or maybe just more challenging.
Yeah, I thought that was really interesting too. Thanks, Steph, for pointing that out initially. I was like, oh, that is different. Any other comments on the methods?
Did they provide any rationale for why you had to have visual representation in the paper? Sorry, I haven't read the paper. I didn't think de-implementation was relevant to me. Now I actually know that it is, so I will reread it or read it later. But
I don't think they didn't
weird.
provide it in the methods, but I think they did in the limitations kind of say that we visual representation of a figure or model was a requirement of their inclusion. Empirical studies that cited use of a framework or model but did not depict it, or for which could not find a visual depiction, were excluded. They haven't really explained. This approach was taken to minimize ambiguity of relationships between constructs and to include potentially helpful resources that can be used in future de-implementation studies, is the reason they've said.
I guess you might, if there's already a framework that exists, you might just refer to it rather than actually illustrate it. So you know, thinking about something like the TDF, not saying that's an implementation framework, but it's just, it can be depicted as a table. So does that count? I don't know.
Yeah, that's right. Just in the chat, Karen, that really is you're right. That is really, I thought that was interesting too, that both papers talked about equity in implementation as well, and low and middle income countries. So the results were they had from 27 papers, they had 27 unique frameworks and models. And at a quick glance, there wasn't any that I had. There wasn't any of the big ones in there, but then they did say at the end in the discussion that sorry, just going to find it. IPARIS and REAIM are looking at improving it to include it. So 13 were empirical studies, 14 were non-empirical, so commentary and conceptual type papers. I thought it was interesting that there were so many different frameworks and things. They kind of rationalize it that the reason for that might be just that there was so many different contexts and different reasons for de-implementation and sort of like the different categories. The most common was that reduce. So any other questions or comments on that bit before we move on? Yeah, that's what I thought too, Natalie. It seems like so many unique frameworks, like just like, wow. I'm
really sorry, but I did read it a long time ago. Did they comment on like the rationale behind their choice of did they summarize that in any way? Oh, am I losing?
Oh no, you're still there. I've just shared the screen.
Oh, okay. Yes, and so what I'm trying to get at is what were the characteristics in these frameworks that address the de-implementation scope of work?
Sorry, what was the question?
In providing well, first of all, did they summarize any kind of rationale for why studies or projects used a particular framework? And if so, was it specifically related to some aspect around implementation?
Sorry,
need to read. Sorry.
Yeah, that's okay. So if you could see the table 2, that's kind of how they divided up. They had the primary action of it, and the secondary action, if it was applicable, and the evidence for the de-implementation framework was, so NR is the not reported, and then whether they reported on cost or whether they involved stakeholders or not. So some of them did, some of them didn't. And these are the non-empirical, but so if you look at the empirical ones, might be a little bit better, but still having that evidence there.
And they kind of talk about it a bit in the paper, don't they, about the different sort of characteristics. But I think the main message in the paper is more that actually you need to be using some sort of framework when you're doing your de-implementation work, rather than sort of saying, this is my favoritist one.
Yes, yes. They haven't really given a guideline of this is the one that you should use, but recognizing there are different contexts. And you can choose, as long as you're kind of using one, which is kind of what we do anyway in main de-implementation. What is going on with toothbrushes in the chat? Can someone bring me up to speed?
Everybody,
I was like trying to read it and keep up.
Sarah, everybody has a toothbrush, but nobody wants to use anybody else's.
Right. The frameworks. Yes. Yeah. We all love our frameworks, don't we? I kind of I'm kind of the opposite. We chose
what, you use other people's toothbrushes?
No. But with frameworks, because we did like the framework that I used for my PhD and things. When we started this new project, I'm like, nah, not using it. I'm going to choose something different. I just kind of went, I'm just almost at random, but not really, trying to choose something that's different. What was Jill's comment about so many frameworks? That's consistent with all the reviews in implementation science. Yeah, people look forward. Yeah. I've lost my Zoom controls. Just 1 second.
I agree with Hasai. I'm constantly thinking that do we actually need to think about de-implementation as a separate thing? Like, I don't know, I struggle with that a bit.
Yeah.
Because you're trying to implement something different or something better, hopefully, either way, whether you're stopping something that isn't effective or isn't evidence-based, or whether you're introducing something now new that is, I don't know, I guess I'm a little bit like over the number of different frameworks and having that smorgasbord to choose from. It's like, should it not just be part of what it is, and why is de-implementation really that different from implementation? I don't know.
It'd be very similar process, right? You're still looking at barriers and facilitators.
Yeah,
you're
of
still
course.
involving stakeholders. You're still looking at costs.
Yep. That was the point of my question was, is it really different? And did anyone talk about it?
Yeah. Sam?
Yes, thanks. I guess I'm wondering, coming from my perspective, which is not much to do with de-implementation. Sorry about my voice. I have quite a bad case of the flu. But it just made me think about the certain implementation frameworks that exist currently. I suppose, imagine if they all had a de-implementation flip side to them. So if there was, okay, this is the actual framework, this is how we're rolling it out, these are the components, stakeholders, like you mentioned, getting across all the levels, and this is what to follow when de-implementing certain components. I'm imagining, again, as someone who's not too familiar with the literature, whether anything like that does exist, like a paired implementation, de-implementation, for those frameworks. And if that's not working for you, this is how to de-implement it. Does anyone, I don't know, have anything to say around that, or think that would be feasible even?
Now we need to put out a commentary from our group just being like, stop it with the frameworks. We've had enough. Just quickly to Natalie before we move on to the next paper, or if anyone else wants to comment on just what Sam has said.
Yeah, I guess it kind of comes around to the, kind of what we were talking about at the beginning, because you've sort of got something that is, either low evidence base, or it's causing a problem, or, something like that, which is kind of, there's a specific need to de-implement that thing. Whereas it may be that there's something that new that you're trying to implement, and then you just need to, like I was saying, replace it. And I think depending on how, depending on that will depend on how you need to approach your stakeholders, and how much of an emphasis is on we are coming in to de-implement something versus we're coming in to implement something new, and that will involve getting rid of the old thing. So I think
which ties in with like what Angela was saying, like people are not going to take that very easily, like to say, you need to stop what you're doing. You've been doing it wrong for years. Just stop.
So I think, and again, I think it's also on kind of like how wide does this spread? So, there might be like overwhelming evidence that something needs to be implemented, and that might be far easier to approach than going into one organization and trying to tackle it that way. So I think there probably is a lot of context around.
I really like Erica's comment. Maybe we need to de-implement implementation frameworks.
I've got one sort of one final comment from me, and I'll shut up. When we talk to the consumers about the possibility of you don't need to get this scan, it's unnecessary for this situation, they were very concerned and very worried that they weren't getting the best care if you weren't going to do a scan. And so that's a whole other side of it as well.
It's also the I think also tying into that is the patient's expectations, like that. Like
that's what
somebody literally said to me yesterday, we're doing this so that we can say to them we've done something, like, and I was like,
see,
like so that patients feel like we've done something for them. And even though the patient might not need bloods or whatever.
Yeah, for sure.
Penny, just quickly, last comment before we really need to get to the next paper.
I just wanted to see if anyone had any thoughts around the use of the socioecological model framework. I didn't think that they had used it at all well. And I don't know if that was just their attempt to, they were trying to say something about a systems approach. So I don't know if anyone's got any thoughts on that. Seemed a bit superfluous to me, but maybe people with systems thinking or SEM experience have a comment.
Anyone?
That was actually the only part of the paper that I read, Penny, and I did actually agree. It seemed very token gesture-ish and wasn't they'd seem to add it in as another framework rather than to actually get something meaningful out of it.
The systems. All right, awesome. Thanks, everyone. It's really interesting to get everybody's take. Steph, have you got anything to add before we move on?
No, let's move on to the evidence paper, because I think this is quite an interesting one as well, isn't it?
This is another one that chose it because, so it's called Revisiting Concepts of Evidence in Implementation Science. And it's written by some bigwigs in the implementation science world. And I kind of chose it because I think it's something that we think we know a lot about, because we always say, oh, we're doing evidence-based practice and evidence-based this and evidence-informed this. But we might not always appreciate what it means in terms in an implementation science terminology framework. Have people read this paper? Just trying to see the nods and the okay, awesome. So it looks like some people yes, some people no. What did we think going into this paper? Did anyone think something different before they read it and then something different after?
I think I was just quite interested to find out another group's perspective on what is evidence and how we use evidence, whether it's capital E or a little e, and where we're generating that from, and things like that hierarchy of evidence. Does that mean, you know, sort of some of that consumer experience maybe? Does that still count as evidence? And I was kind of interested to see if that was going to be incorporated into this paper.
Yeah, exactly. Anyone else want to make any comments before we go in?
I'll follow on from Stephanie and say I read it looking for the community lens of evidence in terms of evidence-informed innovations and evidence, so practice evidence to research, and saw a little bit in there and enough in there to make me feel a bit heartened, but not enough for me to feel confidence. And as an ongoing tension that I have, that we work in communities and we don't use evidence in the way of a clinical setting. Our evidence is much less clear cut about this pill does that or this screening test does this. And it is therefore quite difficult to convince some of my colleagues of the importance of implementation science, because we don't have an evidence-based P always. And so I liked the paper in that it did draw out a little bit of this, but I actually was spurred on to actually take it to the next step and say we can do better, and we can add in evidence-informed innovations, and how do they link to implementation science in a community context. And yeah, got me a bit
maybe that's your
motivated.
next paper.
After our commentary.
Is there things going on in the chat, Steph?
Yeah, there's lots of people discussing the fact that we do need frameworks of some sort, and really, I mean, this and you know, to think about moving into this paper about evidence, but also the fact that we need some flexibility in what it is that we're using and applying. If we have nothing, then it's hard for us to be building on top of previous work, so we sort of lose the benefit of previous efforts. And if we want to say we're implementation science, I think that's really quite important. But also that need that flexibility when we consider all the different groups that we want to be doing our work with.
Yeah.
Penny, I really liked their reflection that EBIs can evolve but still stay true to the original function. Yeah, that's true. You really take into that context and that different where we're putting this evidence needs to be taken into account. We were talking, Steph and I the other day were talking about this paper, and we were talking that, you know, this hierarchy of evidence, the triangle is what you're looking for, and we grade 3, grade whatever levels of evidence, and probably it's not always going to be like that for something that you're implementing. And I was saying that we use an assessment in for our patients, which is the A to G assessment, which you've probably heard of. Maybe it's airway, breathing, circulation, disability. And it just takes you through ABC, which is the life-threatening injuries that patients are going to have. But we've been looking and we can't actually find evidence for it. And we literally use it every single day for every single patient. So it was just interesting that we found that. So this paper is aiming to clarify concepts of evidence, summarising ongoing debates about evidence, and provide a set of recommendations and tools or resources for addressing the how-to in filling evidence gaps in most critical to advancing implementation science. They've actually got some really nice tables in here, which I am definitely coming back to. And I can see myself coming back to this paper again and again to reference it in different things. Table 3, determining when evidence is sufficient. Yes, and I've actually highlighted that one because I thought it might be interesting to actually go through that table as well. Thanks, Natalie. Because it's one of the first things we say with implementation science, that, you know, we've got all this evidence that hasn't been implemented into practice, and implementation science, the whole point of it is to bridge that gap. Is kind of a lot of times how we explain what implementation science is, but maybe, like Jill said, it's actually a bit more, has become more than that. And we need to look at the different types of evidence and things. So there's no like methods or anything because this paper is just a commentary. But I thought I might share the tables. Which I did have open. And I thought it might be a top talking point. So table 3. Hasai, my favorite from the paper, improve understanding of contextual effects on implementation. And this is a good use of SEM table 2. Yeah. So table 1 was the terminology, which again was interesting to read, like just have it all in the one place. Table 2, did you want to comment to everybody, Penny?
No, not really. Just it hadn't occurred to me that this one, because I scanned this one. But yeah, if I'm looking at why you'd bother doing an ACM, this is actually quite useful.
Yeah, they're just all the different context variables and things, having it in one place was really good. And table 3, I thought we could actually read these. Can you guys see that enough?
I can read yours an awful lot better because you've got it. I'm reading mine like this because the paper's all printed like. Why did they do this with tables?
Well, that's why I opened up the web version, because I thought it would be easier to read instead of trying to flip the PDF. So the determining when evidence is sufficient for dissemination implementation, I think this is the age-old question that we're always going to ask, and I thought this might be a good resource to come back to at different points when we're thinking of either implementing or de-implementing something. So how pressing is the health issue? You know, so vaccinations in COVID might have been an important one there. Is there an evidence-based, if so, what is the quality and quantity of the evidence? How long will it take to develop the evidence base? Are there emerging or established health equity issues? If the study addresses social or structural determinants? Is the issue priority among stakeholders? How many, which ones? Are you equipped with to measure a range of contextual variables? Are there resources to implement? Might a hybrid trial that addresses both effectiveness and implementation be appropriate? And is there implementation already happening that you could evaluate instead? Is action going to be taken regardless of whether it's evidence-based or not, which happens a lot? And what are the consequences of not implementing or getting it wrong? Is this kind of where you felt, Jill, that they've touched on it but not enough? What would you have liked to have seen more of in here?
It wasn't this table in particular, it was just through the discussion of the whole paper that they mentioned it, and I'm happy to see it mentioned, but
good.
We could have probably had a dot point in here around how long will it take to develop the evidence base. It is about what sort of evidence is required. Where does the evidence come from? I think there could have been another dot point there. But it's a good paper and I'm going to use it a lot. So yeah.
Penny, third's last dot point speaks to the political and organisational support for change. Yeah. The policy or program, sometimes stuff gets implemented anyway.
Erica, do you want to unmute?
Oh, sorry, Erica, didn't see that.
Oh no, I just put my hand up. I just wanted to make a general comment. I mean, a general comment about the table. I mean the paper. I thought the tables were excellent, and I really like how they've structured everything. And you know, it's very clear that a lot of thought has gone into it. It reminded me though of a broader question around what is the sort of remit of implementation science, and where does it overlap with things like health system strengthening, health policy research, and do they to a certain extent talk about you know, transdisciplinary research with policy? But and it's one thing that I always struggle with is, you know, where are the boundaries? And I don't think that there need to be clear boundaries, but I do feel that there's a sort of move towards going out, and I think that's quite important. But I wonder if we call everything implementation science, then we risk losing some of that valuable expertise that exists and is well developed and defined in other places, especially around the issues around context and moving things to context. I've worked a lot in low and middle income countries, and you know, even though we call it implementation science, there in practice it's mostly health system strengthening with some implementation science stuff built into it, because the reality is a lot of the systems are not strong enough yet to just implement something as you go. So you have to build up the system first. So I think it's a nice start, but I think it makes me think that there is so much more to be done, but also a lot of alignment with things that already exist and knowledge that is already out there being done well by other people.
Yeah, that's the science versus practice. Yeah, thanks, Natalie. Oh my God, we have run out of time already. This went too quickly.
Yeah, Sarah, can I jump in there and just say, thank you very much to Sarah for leading this discussion. And we just managed, when Sarah and I first talking about this, we're going, oh, you know, an hour, we can do 2 papers easy, no problem. And we could have done 1 paper. And as Bella's just said, we need 2 hours next time. So I'd just like to say thank you very much to Sarah for leading this discussion. It's been really, really fascinating. Really encourage you to follow ImpSci Reviews on Twitter and look out for the next Twitter discussion around the next journal paper that will be coming out when, Sarah?
The next meeting?
Yeah.
Did you say? The next one is in June. So we're going to try and do, I've decided to do it opposite to ISIG. So ISIG is every 4 Mondays.
Yes.
or something.
Yeah.
So we'll be the one in between.
The alternate one. Perfect.
The
Sarah,
alternate Monday.
that works out really well. And thank you very much, everybody, for joining in the discussion, because you really have made the session today, sort of without everybody contributing, it would have been far less interesting. So really thrilled for that today. So thanks very much for joining us, and we'll see you in another month's time. Karen, can you remember what?
Thanks to everyone who joined from Melbourne today as well. It's great to see so many different people here. Table 6 was also good in that paper for a lot of resources. Sorry, can't stop.
Okay, we're at 1:30, Karen, so I'm going to end the meeting here. Thank you very much, everybody, for joining us. Toodaloo.
Thank you. Bye.
Great work, Sarah.
Oh, done.
Quite exhausting, wasn't it? I didn't expect so much discussion.